morning, and welcome to Connections Radio Show, where we talk about ideas that matter. I'm glad you've made the connection and are with us today. I'm Lori Fitz, your host, and the goal of our show is to explore a wide range of topics that challenge us to see ourselves, our community, and the world around us, that get us thinking, get us talking, get us imagining, get us connected, and perhaps inspired or challenged to do just a bit more because we made the connection. So we have been dealing with COVID-19 for what seems to be forever, but it's really been, a good solid 15, 16 months. And how are we doing? We've talked about all the challenges in the midst of it, our hopes for a vaccine, the fears, the grieving, we saw hospitals being overloaded. And I think a lot of us are exhaling, but we're really exhaling not completely. We're not sure. Things have changed. And what does that look like? And how do we cope? And what do we do? So I have two wonderful individuals who will be with us today to help explore. We won't figure things out, but I think having a chance to talk about it gets us thinking and gets us perhaps connected a little bit more about what things we can do. So I have Lucinda Brown. She is a healthcare consultant. She's also a trained psychotherapist, and she works at the Occupational Environment Health Network with Tom Winters, who's a doctor, and he has been an occupational health physician for about 30 or 40 years. You've got infectious disease training, as I understand, Tom, and you're a supervisor for docs in training at the Harvard School of Public Health. Welcome.
Thank you.
Tom, we're so glad you're here. Oh, so glad that you're here today. So what I'd like to start out with is, surviving this COVID-19. And we're now at this place where we can pause. But I'd love to have you both share your stories of what it meant out in Boston as you were dealing with COVID-19. I'm going to let Lucinda start, and then we'll shift over and have you add your story as well, Tom.
Sure. So I was working in a hospital in Boston, and I remember March 13th was the day when it all broke loose. And we were starting to get cases. We were hearing about cases of people, travelers mostly, coming into the Boston area and being identified by the Mass Department of Public Health. And, it was just growing and growing. We didn't know if this was going to be similar to flu or not. And there were just an enormous number of questions. And the hospital decided to ask people who had any kind of medical condition where they would be vulnerable to work from home. And they started mandating this. And prior to that, keep in mind that you were forbidden from working from home if you worked for a hospital. And that was very typical for hospitals. If a nurse can't work from home, nobody can work from home. So it was a big shift to say people need to work from home, and it made us all realize this is very serious. And they started calling our department, Occupational Health. We take care of the employees of the hospital. And we were immediately overrun with this tsunami of calls to our department asking very legitimate questions. Should I be worried? Should I be worried about my kid who has cancer? What should I be doing? And luckily, because the hospital had infrastructure, we got an infusion of nurses. We had about 30 nurses join our department. We took over the whole floor of our building. And basically it was like a, MASH unit with extra phones and extra staff, and we just were able to deal with it. But Tom and I met all the time. We'd have daily conversations about what the CDC's new recommendations were that day, how things were changing. It was just constant change and very anxiety-producing for all of us.
Tom, how did it go for you? It sounds like it was similar.
Yeah, no, it was chaos in the beginning, and we navigated the best we could. We had information coming in, but we didn't have good testing in the early part because the CDC had developed their own test that was deficient, and it was missing, 50% of the people that had COVID. So we were taking people with the symptoms that met the criteria of COVID, and those we were excluding people from work. And we did this dance and built algorithms over the months, and they changed every week. We got some misinformation from CDC. Our Department of Public Health was a little slow at reacting. So Lucinda, Deb Barbeau, another infectious disease doc that works with us, and myself, and the infection prevention control people at the hospital. We were at a children's hospital. I also work in an acute care hospital, Beth Israel Deaconess Medical Center, and a cancer hospital. We were all taking the best information we could and building algorithms and kind of sharing them among all of us, the Harvard teaching hospitals in Boston. And we were doing the best we could of taking people out of work, sending them back to work. In the old days, we didn't send them back for 14 days because we thought they were infectious, 12 or 14 days. Well, they weren't. They were infectious for 8 days. So then we could send them back to work after 10 days. And then after they're exposed, we could send them back to work after 7 days. So it was all over the board trying to figure out how to do this properly. And we're trying to protect healthcare workers, which you had to protect the infrastructure of the hospital because the healthcare workers were key. At the acute care hospital, and children's is acute care, but there weren't as many PD cases early on. There are now more PD cases in young kids, but the adults were pouring into the acute hospitals, and the healthcare workers just stepped up. The frontline people, we were really second line, Lori. Mm-hmm. We were in the back room, but we were working and seeing people and sending them to. We set up diagnostic centers, outdoor testing sites, and finally went to some indoor testing sites for the asymptomatics. And boy, it was a mess in the beginning, but we worked hard at getting it right.
How different do you think it would have been if the public health structure hadn't been falling apart for the last 20 years? And if we had a better public health partner, would you felt more prepared, do you think?
I'll give the first opinion. I think our Mass Department of Public Health went on to weekly meetings. They were good, but the doctor there, you couldn't get him to make more on-the-fly decisions. So then it came back, and then they would say, we'll come out with something next week, in 2 weeks. So we were stuck making the decisions. And, I think 90% of the time we did quite well. We looked at CDC, World Health data. We were looking at the Chinese data as it was coming out of there. And, being ID docs and trained in epidemiology, it's not hard to take data that you have, even though it's not randomized controlled trials, and take that data and integrate it into a system that will help protect healthcare workers and patients.
Mm-hmm. And early on, the emphasis was on the vaccine more than medication, right? So how did that evolve, and how looking at medication for folks?
Well, in the beginning, there were no medications except some false the politicians were promoting drugs that had never been trialed and definitely didn't work. And so we didn't have good medications at the beginning. We had oxygen and fluids to help restore these people that had cytokine storm in their lungs, and now they're dehydrated and hypotensive. And so, the acute care hospitals were supporting the organ systems so these people could survive and get oxygenated and hopefully get ahead of this virus. And only when dexamethasone was found, that higher dose dexamethasone, which is a steroid and it cuts down inflammation in the lung tissue, was found to be beneficial. Did we have an impact? Remdesivir was a medication that came out as a pill that it seemed to have some effect against the virus, but that didn't work out. World Health doesn't even approve it now. And then we had monoclonal antibodies that came midsummer that we would infuse into people with mild to moderate illness, and it protected them from developing moderate to severe disease. The most important thing was that they had to be supported by ventilation, and mostly you could do that without intubation. And then they figured out you prone people, tip them over on their stomach. They did better than having them lie on the back with a tube down their trachea. So anyway, it was very interesting.
Yeah. From a public health perspective, you really only have a few tools. Mm-hmm. And at that time, we didn't have vaccine available. So you do contact tracing and quarantining, and that's all we could do. And so, we tried to follow up, and that's where public health was really at a disadvantage because you need just massive amounts of people to do all this contact tracing, calling all these people, finding out who they saw when, and then following up with those people and then asking them to quarantine. In Boston, they started asking for volunteers, and they were trying to hire contact tracers, but that takes time to get that set up.
And training, and who and how does it work even?
Exactly.
I have to imagine that with all the decisions that you've been describing, it must have times felt like, blue wire, yellow wire. Which one do I clip? The decisions were perhaps life and death in the moment. And what could you do?
Well, we were lucky that we were surrounded by really smart people. And as Tom mentioned, all the hospitals in the Boston area collaborated. Mm-hmm. And there were some really proud moments, too. It was crazy making, but the Children's Hospital didn't have as many acute patients. So we sent some of our respiratory therapists to the adult hospitals. We sent equipment, vents that we didn't need. So there was this unbelievable cooperation between us trying to make decisions and then providers going to other hospitals. So that was really great to see.
Well, in our next segment, I'd love to find out more about your personal lives. How did that impact you? Because not only did the hospital and the group of hospitals change, your life changed. And what were some of the challenges that you faced, and looking at your priorities and whatnot? So love to hear from both of you. Thank you so much. And I want to do a thank you to your Occupational and Environmental Health Network and the work that you both are doing in this area. So we'll be right back. I'll just have a few short commercials, and we'll learn more about surviving and what's the next step. Because we're not done yet. There's plenty more that needs to be looked at, and how do we create a muscle memory for change? Welcome back to Connections Radio Show, where we talk about ideas that matter. I'm Lori Fitz, your host. And we've been talking about how we're doing during this pandemic. We've had some positive things happen, as well as really reevaluating who we are and what we're doing. But when it comes to a pandemic, it's interesting. This isn't new. We've dealt with them in the past, and I have two wonderful people to help explore what pandemics are, how they've impacted us, and how it affects us personally. So welcome Lucinda Brown. She is a healthcare consultant, and she's also a trained psychotherapist. She works with Occupational and Environment Health Network, and she works with Dr. Tom Winters, who has been an occupational health physician for 30 to 40 years. You've got infectious disease training, and you're a supervisor for docs in training at the Harvard School of Public Health. So thank you both for joining me to kind of do a timeout discussion. Let's do a pause and talk about pandemics and really how are they impacting us. And one thing that we've talked before the show is a little bit about pandemics through the history. And so to share with us a little bit more about how we can put this in context of history.
Well, it's really interesting because a lot of people are dealing with this sort of for the first time, thinking that we've never seen this before, when in fact we've had the Black Death, we've had polio, smallpox. We've dealt with pandemics before, and we've dealt with vaccines being the major tool and what we want to use. And, smallpox was eradicated by 1980, and it didn't just go away on its own. It was because of a concerted effort globally to vaccinate everybody. But there was still vaccine hesitancy, and that kind of fascinates me because people are again, experiencing that. They're afraid of the vaccine. They don't want to be told what to do. But there was an interesting case at the turn of the 20th century. In fact, it was in Cambridge, Massachusetts. A gentleman there didn't want to get vaccinated. And they had something at the time they called virus squads, which is very nefarious, but they actually would go to people's homes, hold them down. They'd have the police hold them down, and then a medical person would inject them with the vaccine. And this guy said he didn't want to do it. He was afraid it would hurt him. And it went all the way to the Supreme Court. It took many years, but in 1905, the Supreme Court decision was that public health supersedes individual rights, and that it was your role in a civilized society that you have to give up some of your personal freedoms. And that is the issue right now. Yeah. So I think that it's not new.
No. But it became, I think, more strikingly apparent individual rights versus community responsibility throughout this whole pandemic. And the politics, of course, influence this. But there's also the American way of I'm an individual and I'm going to pull myself up by my own bootstraps and I don't need anyone. Well, we all had to need each other during this time. I mean, I can't imagine how frightening it would be to have a virus squad, vax squad come. But on the other hand, I'm kind of glad they did, because it did help get things. I mean, we're looking at trying to get to the 70% first shot by the 4th of July. I don't think we're going to get there.
No.
But it's important that we get there. And how do we get the folks that aren't finding it important enough to do something for the community?
Right.
So, Lori, the best analogy, a comparison of this pandemic, H1N1, those were blips in the screen, but the polio epidemic 50 years ago is the closest to this. The next closest is, of course, the pandemic flu of 1918. And out of that one, we never had any treatment. We didn't have any vaccines. It became, that really were developed then. It was way too early for vaccination development. But the polio vaccine, of course, the Salk and the Sabin vaccines, remember in Minnesota, I received my cube of vaccine, and friends around me were becoming paralyzed.
Right. And you saw the consequences right there.
I saw the consequence of polio. And so that's a vivid memory of mine. And they closed all the swimming pools, and I was in Owatonna, Minnesota at the time, and you couldn't circulate. And it's almost like when we started masking people up both ways, and we're wearing masks outside, which seemed ridiculous to all of us, but we complied and thought, yeah, God, we're protecting people. So, the polio epidemic, I mean, it was droplet spread. It wasn't probably aerosol spread. This is more dangerous. An influenza is supposed to be droplet spread, but in confined spaces, it's aerosol spread. This became droplet spread, but also it became known to be aerosol spread. You go into a room where someone has a high viral load, and you didn't have a mask on, you could acquire it just from that one encounter for 5 minutes. So I think those two analogies are very important just to help us reconstruct where we're at.
Well, I think
now we got to vaccines, but we're not to treatments yet, and we're working on that presently.
Well, I think with the polio, one of the things that I think back, because I remember my little sugar cube, my family's from Minnesota, but we were living in D.C. at the time, was that there was no question. There didn't seem to be, at least there didn't seem to be this, it's not I don't have to take this sugar cube.
Well, actually, there was a case where, it's called the Cutler incident, where there was a girl that was vaccinated and she got polio in her arms. And I don't know what year this was. It was in the 50s, but they thought that was odd because I guess it usually starts in the legs. And it turned out to be that the vaccine itself was somehow tainted, and it led to better oversight of the manufacturing of vaccines. So, people now say they're worried about what's in it and is it safe, and, that's huge to have a safe, effective vaccine. But some of that came from errors in the 50s.
And the sugar cube, remember, was a live attenuated vaccine. So one in several 100,000 people got polio from the vaccine. And then the Sabin vaccine came, which was an intramuscular one, and that was a dead polio virus that people didn't develop, but it was really a small number. So, and then now these vaccines have nothing to do. They're not live vaccines like measles and varicella. These are dead vaccines, and they're just taking the spike protein and using it to build IgM and IgG antibody once you inject it into humans.
But I hear some people are afraid somehow it's going to change their DNA. I mean, there's these great weird conspiracy theories about some of that, and it gets then back to what do you believe in science? It almost becomes down to what's the truth. I mean, who do we trust?
But that's important.
Yeah.
You can debunk that because this is a messenger RNA virus. It doesn't even get into the DNA. Mm-hmm. And so some of these vaccines, the adenoviral ones, they don't get into the DNA of our cells. They do their thing by helping to build antibodies in other cells in our body. So it's pretty crazy how people have perceived this.
And for me, it comes back down to truth. I mean, science for a long time is something that we all could kind of shake our heads and go, well, yeah, that's science. But now when you have individuals that are not wanting to believe in science and they want to, not believe in replicability and all the good things that science gives us and want to create a conspiracy story, I mean, they're the ones that are going to be most at risk right now. I look at the southern states with very low vaccinations. And this variant of the Delta that's now Delta Plus is looking really dangerous. And what could that look like? And for me, part of it also was when we were looking at wearing masks and making sure that we had our vaccination, it wasn't just for ourselves. It was for the people we loved, who are vulnerable. How are we connecting with the people that we love and giving back through our gestures, whether they be how we wash our hands and put on a mask or get a vaccine? How are you coping with folks that are denying science?
You have to spend a lot of time with them and teach them the science. And I think we remind ourselves that the CDC got tainted partway through this last administration because they attempted to infiltrate political statements to CDC statements. So we couldn't believe everything coming out of CDC. Remember that, Lucinda?
Oh, yes.
So the trust there gets broken.
So now with Walensky, I mean, it's coming back, and I think the trust. But CDC, the Morbidity Mortality Weekly Review is kind of the Torah, the Bible, that we look at weekly as infectious disease docs, and that information just was misinformation coming out of a federal agency. So now it's back. So we spend a lot of time coercing, just teaching people science, and a lot of these people are apathetic. They've kind of put this off to wait, make sure everyone else didn't have bad reactions. They didn't have time to get vaccinated. There's hesitant people and apathetic people, two groups, and it's very challenging. I'm on a committee, a national committee, to try to figure out how do we break through with this. And the religious leaders of all sects have stepped up, and they're doing that work in the temples and mosques and churches, and then going to the community and the primary care docs, and it's all hands on deck, and everyone's doing their best at getting to this. But I think there's still that group.
Primary care docs are key here because they have one-on-one conversations with these people aside from, their group of people who are, holding signs and voicing their anti-vaccination opinions. So that can be where somebody can ask questions like, what is really in this and what does this do? And they trust their providers, generally speaking. So I think once the primary care docs get the vaccine, I don't think they do right now, but I think it'll be a lot easier to reach some of those people that are still holdouts.
Yeah, they're distributing it up here in New England now, and most states have given them access to the vaccine. And I agree that the people have relationships with their PCPs, and they trust them, and that's the best person to do that messaging.
Yep.
And as we talk about trust, my radio station trusts me to go to commercial. I have sometimes run through it. I ran through this one as well. So I do need to take a break. But thank you for joining us on Connections Radio Show as we discuss the pandemic and our ongoing challenges and how do we make sense out of all of this and how do we start coping with change in a new way? So stay with us. We'll continue our conversation and learn more about ways to be thinking about this with both Dr. Tom Winters and Lucinda Brown. Connections radio show, where we talk about ideas that matter. I'm Lori Fitz, your host, and I have two terrific individuals who are sharing ideas with us about living with the pandemic and challenges that we faced and challenges that we continue to face. They're both with the Occupational and Environmental Health Network. We have Lucinda Brown. She is a healthcare consultant, and Dr. Tom Winters, who is an occupational health physician. So welcome, you guys. So glad that you're here and exploring these ideas with us. And we've been talking about how the pandemic has hit us, pandemic through the centuries. How do we deal with change? I think one of the more critical issues that are facing us is going back to school, and especially colleges and universities.
Yeah, it's very controversial. There are many colleges that are requiring the COVID-19 vaccination for their students. And there's a precedent for that. They already require measles, mumps, rubella, chickenpox. You know, that's pretty common for daycare centers, elementary schools, and colleges to require these vaccinations for students. But they're struggling with the staff. Do they require it for faculty and staff as well? And the debate is, we know that if you mandate a vaccination, that your vaccination rates increase. But it also can create some ill will. So can you get a close enough vaccination rate by using incentives and peer pressure to encourage people to be vaccinated without having to be heavy-handed? Is it worth it to be heavy-handed about it? And
so peer pressure amongst staff?
Staff, yep. And a lot of people do want to do it, but then there's people, of course, who say you can't make me and I don't want to do it, and I'll do it if I have to, but I don't want to. And so, but I think for a college and university, those pools are so intermingled. They're in the same labs, they're in the same classrooms, the same athletic facilities. I think it's hard to mandate it for one group and not another.
Well, we're all humans, right? I mean, it's not like there's some sort of special difference between a staff and, and a student.
Right. And we often think about the rights of the person that doesn't want to be vaccinated. Well, what about the rights of the person that is vaccinated? Mm-hmm. And they come back to work, whether it's in any kind of office environment or a college, and they're vaccinated, but they're working with people who are unvaccinated. What if they feel unsafe? What if they claim that now their employer is not providing a safe environment for them?
Well, Tom, I have a question about that. It seems to me that when someone does get COVID, that as a host, it actually can change the COVID-19, right? So we've got the Delta variant. It seems that if you have more of these going out there, the variants are going to get multiplied, and that it becomes more dangerous to have these variants, and dangerous for folks that may have even had their shot. Just because you've had your shot doesn't mean that you won't get sick. It just hopefully you won't get as sick and you won't have to go to the hospital. But what if we get a variant that does get you that level again, where you might have to go to the hospital?
Yeah, two answers to that, Lori. So the variants so far, our vaccines have outstripped the variants, so we're ahead, even with the Delta variant, and that's important. And then what you should know is that in these asymptomatic testing programs at universities, at least in the Boston area, where students are mandated to get tested twice a week and faculty once a week, that we're seeing 8 people have been vaccinated, and now they have their PCRs are positive. But guess what? They're asymptomatic. They have very low viral loads, and they're probably hardly infectious.
So the vaccines work.
That's the good part.
Yeah.
The vaccine works.
Yeah.
And so the people that aren't vaccinated, they're going to get sicker, and we're already seeing that in some of the pockets around the country where they have vaccination rates in some counties of 30%. And those people are getting sick and in the hospital as we speak.
And they're continuing it. They're continuing having it be part of our life. I mean, if we had more people vaccinated, it seems to me it wouldn't be as big of a threat. But as it just seems to me that we are putting people at risk by having people not take the vaccine.
Yeah, we're ahead of it now. And then you should know, and I'm expecting CDC in the next month or two to come out and tell us that we'll need to get people who've been vaccinated are going to get our booster in the fall or winter, and that'll be the mandatory vaccine. Most of the Harvard teaching hospitals just last week are mandating vaccination for healthcare workers, this vaccination, because of the challenge down Methodist Houston Hospital. Several of the workers challenged the vaccination mandate that they had made. A federal judge threw it out, said the vaccination, public health, as Lucinda said earlier, overrides personal rights.
And the community does deserve to be in a healthy environment. How have the employers reacted to employees asking, "You're putting me in an unsafe environment"?
Well,
just Lucinda, you can explain that. We've done that with flu. We offered an out for some people. Lucinda, explain that.
Well, I think some people are they're just not sure yet because a lot of this hasn't played out in the courts, specifically for COVID-19. With flu, it's a little bit different. Some places say if you can't get the flu shot, you can wear a mask, which Tom and I agree is very hard to enforce, though now people are more used to masks, so that's a little bit better. If somebody is, concerned about other people not being vaccinated, they might be working from home. We might have to be looking at reasonable accommodation for them. And it raises the question of working from home. Is that going to be a permanent thing in our future? We found that in the past, a lot of people couldn't work from home, and then they were told they had to work from home. And it worked pretty well. And all the fears about we'd never be able to manage productivity and people would just, sit around doing their laundry instead of working, we found that was all unfounded and people were very productive. And it's going to change our future in the workplace because more and more people are going to prefer to work from home, at least part of the time. They don't want to deal with the commute and the expensive parking and crowded cities.
Well, the cities may become less crowded if we're not having if we're not having commuters and more people are working from their home.
And the same with universities. I mean, there was a lot of classroom work where people were able to do it from home. Not everything, a lot of training is hands-on, especially clinical training. So that can't be done remotely, but a lot can be done remotely. So it's going to change everything.
So we're going to allow religious exemptions in these hospitals and in the universities as well. But the most important thing is that these people, they're essential workers, and you need to have essential workers on the front lines. So they can't work from home. So the EEOC has told us that an employer can mandate that people be vaccinated that return into the work environment. So I think the the justice system is supporting us as we speak. So I think we'll get pushback, but we're not going to get a lot of pushback. And I think we're in a better place than we were for mandatory flu vaccines when we did that 10 years ago. And you should remember, this is much better effective vaccine than the flu vaccine.
Well, you bring up the EEOC, but what about OSHA? I mean, I know that's being pushed as well, safety. Is OSHA being explored for how folks feel about safety in their work environment?
Yeah, OSHA came out with a standard. They have an OSHA COVID standard, came out about a month ago, and it's just stating all the things that we're already doing to protect healthcare workers in the workplace. So it doesn't give us any new roadmap to explore because we're already doing it. But I think the Labor Department came out with a standard, so it's an OSHA standard now, how to protect people during the COVID period, and so I think we're already in good shape because we've been doing it and we know what to do.
Well, I know one thing, Lucinda, that you've mentioned to me before is there's expectations on employers about what that means and expected health benefits and expected what they do. But what are we expecting employees' responsibilities to be?
Right. So we expect a lot of our employers to provide health benefits. What about the employees? Are they expected to take a role in this and not work when they're sick? It wasn't that long ago when people would say, I've never taken a sick day in my life, and that was some, badge
Pride.
of honor.
Yeah.
And I want to say, well, that's just stupid because what it means is you went to work sick and infected your coworkers. So that's, everybody gets sick. So I do think that there is a responsibility on employees to stay home when they're sick, to do what they can do, to comply with whatever the requirements are of getting vaccinated, wearing a mask, staying 6 feet away from other people if you're indoors.
I think some of it comes down to that fear and trust thing again, because there are some environments where if you do take a health day, it may be looked down upon. Even if it's a good thing, you should be. So how do we create an environment that everyone expects to take sick days?
This is all a culture shift. This is a huge culture shift to expect people to take care of themselves, because that in itself will be better for everybody in the future. In hospitals, people work sick all the time because they feel this responsibility to their patients. And Tom and I have fought this for years, that you're not really doing any good to your patient if you come into work sick.
Right. And you can make it worse, actually. You're putting you're bringing into the environment some sickness that may not be good for that patient.
Right.
So we came up with COVID pay during this pandemic, and the hospitals would pay people their salary to be out of work. They didn't have to file for short-term disability, go on workers' comp if it was work-related. So that worked. And now back to, Lori, to your description of the employer's responsibility. The employer has a huge responsibility in post-COVID long-haul symptoms. 50% of people that were hospitalized have one or more symptoms after they've recovered from COVID. People that had mild to moderate disease, about a third of them have symptoms. And these symptoms include physical symptoms of shortness of breath, chest pain, fatigue, and the other and psychological conditions include anxiety, depression, personality changes, and then brain fog, which is reported cognitive. So we are trying to get these people back to work, and so employers have to bend over backwards to let them, as Lucinda said, do some telehealth work, but then some on-site work, and let them work, 4 hours every other day, build up to 8 hours every other day. But don't have a flexible program and get these people back to work, because someone with fatigue, and we've all been fatigued in our lives, and post-viral illness, there's a thing called fatigue, post-intensive care unit syndrome. Mm-hmm. We've all seen it in acute health care. People are just wiped out after an infection, bacterial or viral, for months, and then you have to help them get back on the horse. And we advocate them, and we have to have employers embracing them and letting them get back to work.
It's all about embracing some change and being open to that. And traditionally, people are not too excited about change. But I think with this amount of change that we've been dealing with, perhaps this is the best time to be looking at what do we need to do differently in the future. And we'll talk more about that after we take a quick break for some commercials, and we'll come back and wrap up. What are some ideas for us to all think about? We've taken a pause and looking at how has it impacted us. How can we figure out how to do things better and prepare for future pandemics in a more powerful way that allows us perhaps to be flexible about change and to maybe even listen to our scientists. So we'll be right back after just a few short commercials. Thanks for joining us. Welcome back to Connections Radio Show. I'm Lori Fitz, your host. We've been talking about what can we take away from this whole experience with the pandemic, and we have two wonderful people sharing some insights with us. We've got Lucinda Brown. She is a healthcare consultant for the Occupational Environmental Health Network. And we have Dr. Tom Winters, who is an occupational health physician. And you both have been working a lot in the Boston area. Lucinda's back in Minneapolis now, so we may see her to be doing some projects here in the Twin Cities as well. But your references and your thoughts and your experiences that we're sharing about today are mostly about the Boston, your time in Boston.
Right.
And looking at where do we go from here? Cinda, give me some insights of what you think. I do believe we're at a sea change moment where our world is changing, and
right.
I'd love to get your insights of what that means.
So I think it's really important that we have structure, that we have experts that we believe in, and that those people have other people, watchdogs, ensuring that what we're getting is accurate and true. It's important that we trust those people and that they have healthy scientific debate so that the facts come out, and it's important that there's complete transparency. If a drug doesn't work, if a treatment doesn't work, we need to know that. And that's really critical for us to believe in what's coming about so that we can use these tools.
And it's okay to ask those questions.
Absolutely.
It's important. Dr. Winter, what last thoughts do you have for us?
Yeah, we need mutual trust among workers that their employer is going to do the right thing by them. They need to have a vote in that decision making, and I think that everything's going to change because there'll be more people working at home, people on site, and there has to be a mutual trust among all of them. And I think it'll be successful, but it's all changed because of COVID, as we know.
Yeah.
And I think where we go will kind of reflect the strength of our society here in America.
Well, Dr. Tom Winters and Lucinda Brown, thank you so much for joining me. I hope that I can persuade you to come back and we can continue this conversation of where do we go from here.
Thanks, Lori.
Thank you. And thank you for being part of our conversation today, for listening to Connections Radio Show. Look forward to having you join us next week as well. Have a good week. Stay connected. Find ways to make a difference.